So I think the answer to that question is she really has MGUS. The rate of transformation to myeloma is said to be 1% per annum. And so if you think that you've been there for 10 years, maybe that gives you a chance of 10% of transforming. It's just that statistics don't work like that. If you've had it for 10 years, your risk in the following year is still only 1%. So you should be pleased with yourself, carry on having it monitored, but you don't really need to think about whether you're going to have high or low risk myeloma when it changes, because it's probably never going to change.
So one of the features of cancers that is different from normal cells is that they can change. The core is the same. So at the break, we're having some discussion, like if you're a myeloma with a 4, 14, 11, 14, always be like that, but there's gonna be some extra changes, gains and losses. The more the cancer changes, the more aggressive it is, and the worse usually things are. Cancers that are very, very stable, some of them are almost like benign cancers. And is that capacity to change what makes the cancers be more aggressive?
Not long enough. It seems that in the patients that relapse, the CAR T cells often weren't there. And so that seems to be at least one of the mechanisms of relapse. And so I think there's a lot of interest in ways that to make them persist, and that we're still learning. Yeah. So overall survival is staying alive.
You can die of many causes. Okay, so there's tumor-specific survival or myeloma-specific survival where you relapse of myeloma, or if you're age 65, you're on a survival curve anyway. And so you have to correct sometimes these survival curves for what you'd expect in the normal population. And so that's what I was getting at by this cure fraction, is when your survival matches an age match control who doesn't have myeloma.
So I don't know that they necessarily need to plan for it, but they can be hopeful that it exists. And so, currently patients who are failing daratumumab right now would be the kind of patients that might be considering a CAR T therapy. That's one of the criteria for the clinical trials that we're running right now. And I think if you find yourself in that situation, then you'd like to look and see what your opportunities are and see if there are any trials for which you're eligible that you could enroll in. And I don't know.
Can you explain? So we had a kind of conversation about the trial design for CAR Ts and the trouble that I've run into with them, which is having 4 or 5 patients waiting, but no real opportunity for them to enter a study.
Yeah. It's the way these trials have a certain number of spots, and they might say, okay, the Mayo Clinic, you've got a spot available in 8 weeks or 6 weeks or 3 weeks. And then, the patient needs to be off therapy for a certain amount of time before they can go on to it. So you have to think, well, do I stop this patient's therapy so that they can be eligible for the trial? But if the therapy is working, why are you going to stop it? But it begins to be very, very complicated to figure out how you time all of these things. No, I mean, you should take the best available therapy that's open to you. The only thing that is an issue now, but I'm not sure it's going to be an issue in the future, is that a lot of the CAR T cells all target BCMA. So if you get another kind of BCMA therapy, and there's some really good ones, these bispecific antibodies and the drug conjugate from GSK, then you're not eligible for the BCMA CAR T studies. And vice versa. If you get a BCMA CAR T, then you're not eligible for those bispecifics. But I don't, if you get a spot in any one of those trials, I would take it. They're so hard to get, and those therapies are effective. And I wouldn't worry about whether it was the bispecific or whether it was the CAR T cell. I mean, assuming that you're in a situation where you need such a therapy. So I don't think you really need to plan for it. I think just take the best therapy that's available to you today, and the future will take care of it. That's what my father always told me growing up. Just do a good job today, the future will take care of itself.
So, frequently people go to well women, well men checks, annual checkups. You go for something else. You have a blood test. There's an abnormal protein in it, and then you investigate further. So that's the commonest way it's picked up. Yeah, so it's called the protein electrophoresis test. You often don't get it, but if the average protein in the biochemistry test is elevated, if you've got a good doctor, they'll say, okay, myeloma and MGUS could be one reason why it's elevated. No, they have to have some degree of suspicion. Yeah. It's a really good question. So I'll get a waffle a little. So if you assume that there's two approaches, those translocations, which are one group, to get a translocation, you have to have a double-stranded break in your DNA. So a cut here and a cut here, then they have to swap. So anything that will cause a double-strand break can increase your risk of myeloma. So radiation, probably benzene, some solvents, all of those things, plus what goes on in your cell all of the time, which is reactive oxygen species. So that's one thing. The other thing is what causes multiple copies, so hyperdiploidy. And that happens when a cell divides. So one cell gets extra numbers of chromosomes, and just that alone can make it unstable. And if you do that in the lab, those cells have the features of cancer in the end. So it's a combination of bad luck and things in the environment that increase the frequency of things.
Yes, I would add on to that. If you've got inflammatory conditions, the more time your immune cells have got to respond and make antibodies, the more likely they'll make a mistake at some point along the way. And there's about a twofold increase. You go from 4 in 100,000 to 8 in 100,000 with some kinds of inflammatory conditions. And the other thing I'd just like to add is that I engineered someone to get myeloma. Someone was a mouse, but I took a mouse that had MGUS, and I engineered it so that you would turn on an oncogene, a cancer-causing gene, just at the critical time when the plasma cell is going through all of these changes. And that mouse uniformly develops multiple myeloma. So, I mean, we can, but if I wanted to give a person, I don't know how to give someone that I don't like myeloma.
You know, we know, in no small part because of the work by Leaf, how myeloma starts. But I always tell people, to the best of our knowledge, there's nothing we know you did or you didn't do that makes someone start having myeloma. Now, we know now that everyone who has myeloma has had an MGUS before. How do we know that? There was a study in the Army where people collected blood on a yearly basis, and of thousands of people, lo and behold, 60 of them had myeloma, and then they went back and they all have had an MGUS before. They just didn't know it. And there's another study from Mayo Clinic that they did with some math models that are hard for me to explain, and with epidemiologists, that they said, okay, once you diagnose someone with MGUS, how long before has that person had the MGUS? So they looked at the literature that exists for the HIV when they were trying to determine, okay, if you're HIV positive, how much time before you've had it? And there's some good models that predict that. It can be for 20 years or greater sometimes. So I actually think that myeloma starts in most people when you're a young adult or even a child. And it just takes a lifelong of persistence of that cell and maybe growth. And why so? Well, that's the time of our lives where we have the greatest exposure. That's when our immune system is in training. or at least a greater number of training events happen for our immune system. And in fact, I think that if we had even better tools to go deeper than what we can go to detect MGUS, a lot of us have a few cells that are abnormal in the background. It's just that it peaks in a certain small subset of people. In fact, we know that there's a parallel to this. There's a lymphoma, something called follicular lymphoma. And half of the people in this room have follicular lymphoma. And we don't know that. Half of the adult population has some cells that have follicular lymphoma in their system, and they just, cause no consequence.
Yeah, so like it's a good observation. And so cytotoxic chemotherapy like melphalan or adriamycin cause secondary leukemia. So like it's unequivocal, and it peaks 3 years after you've been exposed, and then by 5 years the risk disappears, and it kind of increases the risk of secondary leukemia by damaging the DNA code. Yeah, so you could argue, so that's why maintenance never worked with chemotherapy, because ultimately you would delete P53, then all you would be doing is damaging other places in your genome, activating oncogenes and switching off caretaker genes, and then it's inevitable you get cancer after a while. So there are things that we really do understand, and therapy-related kind of leukemias and lymphomas are very real. So here's the rub. And so there's this thing called CHIP, clonal hematopoiesis. And in the normal population, you can detect all of the genetic features of acute leukemia, and we all have these cells in our background, but it's only certain of us that ever go on to get leukemia or myeloma. But it's kind of, I don't know, the last 3-4 years, this has become very, very obvious. Mm-hmm. So I guess the point is, if you ever have a genetic test and it says you have a mutation, you should think twice about saying that defines you as having cancer, because normal people can have mutations as well.
Okay.
So up until now, it's been used in late-stage disease. And so some of the data you've seen is when it's been used at first relapse. And in first relapse, people are doing very well, and not so many of those patients have relapsed. It's going to be really good in the upfront setting. So, like, I forget what the exposure was, and there was a cluster of leukemias in Camp Lejeune. And I think the point is, it's very hard scientifically to put an exposure to myeloma, but from a legal basis, you can make the argument. And so exposure to Agent Orange in some fashion is payoutable in terms of the Veterans Association. And so it was the same association as that. I'm not sure we learned anything about the biology and exposures that cause myeloma from studying the event at Camp Lejeune. So it makes sense to me. The data that is used to make these arguments is very loose, and so it's petrochemical workers, and they judge exposure based on whether they were serving petrol, worked in an oil platform, and the data is based on 3 cases. Okay. And so it's very hard to fully get to the scientific basis of it. What we know is if you kind of put benzene into people, they absolutely will get acute leukemia. I mean, it's unequivocal, and they did that in China in shoe workers.
Isn't benzene an ingredient in Agent Orange also?
Not that I'm aware of.
Thank you.
It is in many ways. You get hooked up to the same machine, and your cells are taken out. So, but you don't need to get those injections of the growth factors ahead of time. They just take out the normal cells that are already in your body. But what's it? How long is the process? It's a day, I believe. But we think of it basically the same way because it's a cellular therapy, and patients get sick and have to go to the ICU, and for those reasons. But actually, I'd like to have Dr. Fonseca. He seems to have come up with the best analogies. Have you come up with an analogy for this?
This is the elephant in the room.
Analogies. Well, no, it is the same, except that the CAR T cells are trained assassins. Okay?
Ninjas. So.
Your own stem cells, when you have a stem cell transplant, the stem cells have no treatment power. The power comes from the melphalan. What the stem cells do is they rebuild the bone marrow. But the CAR T cells, you take them out, they're trained, meaning they're transformed genetically, so they express those markers that will make them anchor on the myeloma cells. So when they're given back, literally, they're like trained assassins. They go and they attack the myeloma cells. Just by putting them next to the myeloma cells, they actually attack it and don't consider it a self. And in fact, since you asked for a metaphor, I gave a talk with CAR T cells, and I used the story about the frog and the scorpion, right? That the scorpion convinces the frog to cross the river. A T cell is like a scorpion. As long as it's on top of the frog, it's going to try to poison it. And that's what CAR T cells actually do. And in fact, I don't have the video here, I don't think so, but in the internet, there's a few videos so you can see the T cells, how mean they are. They latch onto the target cells and they don't let go until they die. It's really, really quite a sight because they can do this with fluorescent probes, and it's worthwhile looking at.
The other thing is that they replicate. They reproduce themselves, so they don't get consumed.
So I told you I was depressive. So there's important manufacturing things that have to be considered. Okay, so. Can you get a project, a product from everybody? So, are the T cells exhausted when you collect them? Do all T cells switch on to the same extent? They have to be taken, shipped off to a factory somewhere, then they're manipulated, sent back. So there's all sorts of kind of interesting things play out in that setting. Which T cells does the construct get into? There's a lot, and so it's not entirely clear how all of this will play out. But I think what is clear is the constructs that are used now won't be the same constructs that are used in 5 years' time.
Thank you. I actually have an image here of a CAR T cell. I want to show you a CAR T cell. Like, it's not exactly that, but it's a similar idea. And here's the analogy with that scorpion and the. So what you're gonna see here on the right. I want to play this video. You see how the cell attacks the target cell, and that's pretty much what happens. Those T cells have latched on to that target cell, that cancer cell, and this is coming all the way to other forms of cancer. This is coming even for solid tumors. It has worked already in some brain tumors, and there's other clinical trials, but it's all related to that. And that's something that we really are quite interested in developing further. So.
Yeah, I don't. The T cell certainly replicates, but I don't know whether it replicates and then one of them goes off and kills and dies, and the other one keeps replicating. I don't know the answer to that. I think they actually may have less, but I haven't heard of anything of them having more. And I think I heard somewhere that they actually have less. And I don't think that any of you should be really concerned about the role environment played in your getting multiple myeloma, because it's a multifactorial disease, and I think environment is probably one of the smallest parts of it. And there's nothing you did wrong or nothing that happened to you for why you got it. It's just the way it is.
And it's so hard to know, because if you're, like, let's say you work on a petrochemical factory and you were exposed all of your life and you get myeloma, it could have been that simple cold that you got when you were 18 that maybe started the tumor. So it's impossible to reverse, search exactly what gave cause to myeloma. And obviously, we want to know about those causes because there's like general health recommendations. Just like it came out, don't smoke. Lung cancer is clearly associated with smoking. It's very hard to know about the other ones. So I think there's the legal aspect. Agent Orange recognizes it. One of our colleagues recently published a paper about first responders to the World Trade Center. It's possible. Do we know it for sure? I don't know. I remain a little bit skeptical, but no one knows for sure. It's because it's just so hard to link the two things together.
You know, following the atomic bombs in Japan, they looked for an increase in all kinds of cancers, and they saw them for leukemia. And initially, they saw an increase in myeloma, but it wasn't honestly clear if it was because there was more myeloma or they were just looking for it more. And with the long-term follow-up of 50 years, it was very, very long, they looked at the death rate. And there was no change in the death rate from multiple myeloma following the atomic bombs. So some people sometimes mention radiation, but I don't think there's very good data to support radiation causing myeloma.
And I'm sorry we're extending the answer, but I think the most important thing is what Leif said. I think for peace of mind, I don't think there's much practical benefit, but neither is there specific knowledge that would make you think, gee, I wish I hadn't worked those 5 years, in that factory, or gee, I wish I had done this, because we just don't know for sure. I personally think it's just an accident of nature.
I'm going to editorialize on two things, and I normally don't do this. In the 20 years that I've met patients, and one of the things that is just a constant thing, patients always worry about, how did I get this? What did I do, and how did I get this? And my answer, and I don't know if this is the appropriate answer, but this is the answer I give them all the time, I tell them, don't worry about it. Now, when the day comes when the knowledge of how you got it is going to help your therapy, then I'm interested. But if that knowledge is not going to help your therapy, then don't obsess about it. It's, it's just, it's like it's like my favorite talk, or my favorite joke from the South. Do you know why you should never try to teach a pig how to talk? Because it frustrates you and it annoys the pig. and that's how I feel about, so what? And so that's just an editorial comment, and that's what I tell people. If it's going to help, if that knowledge is going to help your cure or your treatment, then that's great. Until that time comes, don't worry about it. The other thing, and I'm going to be writing a piece soon that'll be published soon, and I think this is important for everybody. I think it's December the 20th of this year will be the countdown of the deadline for 2 years. There's a thing called the September 11th Victims Compensation Fund. And one of the things I think you should be aware of, it generally helps people who were affected by September 11th, and there are a number of diseases that are covered and they are eligible for things. And what I tell everybody, all my friends who were in New York at that time and the people around the Pentagon, is if you were around there for weeks after, and if you could still smell things and all of that, then you were exposed to this stuff. And so you just have to be careful. You just have to get your tests done to make sure. It doesn't mean you got these diseases, but you got to know. But you can do a great job politically, and I think this is something that all of you should do. The deadline for applying for these funds is in December 20th, 2020. And all of us who work in cancer know, anybody who works in cancer knows, that there is no timetable for when you are exposed to something and your cancer manifests itself. My mother's best friend smoked cigarettes for 6 months when she was 18 years old, and when she was 55, she had severe lung cancer. So these things, so that deadline of 2020 is just an artificial, arbitrary date. So one way you can help, one way you can help September 11th people, and I remember all of us, when that happened, we all just thought, what can we do to help these people? And you can still do something. And what you can do is you can let your individual members of Congress around the country, wherever you live, your members of Congress, let them know that this is important and that this deadline is, if you know about cancer, it's useless. It's meaningless, because there are people, the thing when September 11th happened and I was in Washington, D.C., and I remember the first thing that came to mind when I watched these people inhaling these things was the long-term death toll of what happened today is going to be much greater than what happened today, and that's turned out to be the case. So this is a way you can help September 11th, and I apologize for the sermon, but I think it's really important. And again, what I tell everybody, when you're diagnosed with myeloma, you become a member of a new community that you never wanted to be a part of. You're a citizen of a new community, and this is a way for you to express your citizenship because you have knowledge about this and you can share it with other people. So with that, anybody else have a question?
I have a comment I want to
Yes.
follow up, is the role of the microbiome. I don't know if it's a new thing that we're studying in all sorts of different fields of medicine, but there's a microbiome that basically you get from your mother as you pass through the birth canal that populates your GI system, and it has influences on your health and throughout your life. Some things, there's nice things that you can do with mice that you can't do with people. And one of those is I can take identical twin mice, one of whom has got myeloma and the other one doesn't. And I can take the mouse with the myeloma from the mouse with myeloma and give it to his twin who's healthy, and the myeloma will grow there. But if I take that identical twin and I first give him antibiotics, try and change or erase his microbiome before I give him the myeloma doesn't grow. So there's something, some microbiome or something that is fostering the growth of the myeloma cells. And so we just published this. If we look at patients with smoldering multiple myeloma, they have in their serum a cytokine that's a marker that's associated with the bacteria that's growing within them. And if they have this marker up, they progress more quickly. And in the mice, we can give them, we've identified the different kinds of bacteria. And if we give the mice the bad bacteria, the myeloma grows faster. And so we're starting to do these studies in people. And so the day might be when someday we identify the right bacteria that doesn't foster the myeloma growth, or the diet that doesn't foster the bacteria that foster the myeloma growth. And we might come up with a probiotic or some way of changing the microbiome in a positive. We honestly don't know how to do that right now. But I think that's another way we might. And patients always ask, well, is there something I can do, something I can eat, something to change? And there might be, we just don't know what it is.
There may one day be a yogurt for cancer patients.
You know, we have a growing number of patients that have used that, also the standard sort of medical marijuana. It was fun at the beginning because when you cover the service on the weekend, you would get phone calls like, I already have 3 gummy bears, can I have 5? It's like, I know you can't overdose, so let's go for 5. Sure, no, sure. But people use it for other symptom control too as well. And I have had a lot of people that have, particularly I think, nausea and well-being. I have been a little bit less impressed with pain management. But I think everyone is different, and it's something that has to be tried if there's no other solution that would work for you. I think, but from what I have seen, some people do at least get some relief of the constitutional symptoms.
I'm not aware of any. I always tell my patients to follow a well-balanced diet. The drugs that we use seem to have a much more important role than almost anything else. But I think it's when you have patients with MGUS or smoldering myeloma, when they're not on any drugs, and they're wondering if there's anything they can do. And there might be some diet, but I don't think we've got any evidence to point us in the direction of which is the right one.
So the Sky92 is just one of the analyses that it's available for prognostication by gene expression. It came out from a Dutch group, and I think they're offering it now. I think it's at no charge. It's at no charge, but it's going to be a commercial test soon. But the laboratory has to send it out. Sometimes it happens that with the signatures, people spend a lot of time arguing. It's like, oh, this is a better signature than this other. I think it's been well validated, the Sky92, just like the one for the University of Arkansas. And it's just one of the many ways into which you can determine the risk category for the patient. I think someone could make the argument that's better than the fish, and I think when it comes down to the power, it gives you information that you wouldn't get otherwise, including how fast the cells divide, how resistant they might be to the treatment. The only challenge is you need to get a good sample, so you need to have enough cells so that they can actually sort the cells out. But if you have that, I think if you had to choose one versus the other, you could say I'm just going to go do the sky. And so that's still something that's being considered.
Was there somebody?
There's a lot of study on the role of the microbiome in health. In fact, I don't even know most of it. And they're looking at it in all aspects of disease. And it seems to be an important contributor. So yeah, there's a lot of research going on there. We would use the original stem cells we had banked. We think that they would have been exposed to less of the drugs over time, and also perhaps there might be less tumor cells when they were harvested. So we would almost always go back to the original ones.
What's the difference?
Right, so the difference is the timing. The tandem is done 6 weeks apart. The salvage transplant could be done is usually done several years later. But in the end, you get the same amount of therapy. And I think that's why, if you get the 2 transplants right away, or you get 1 transplant now, 1 transplant later, it seems as though the outcomes might be similar.
So AMG 420 is a short half-life bispecific. So one of the sides targets BCMA, which is that target that we were talking about. The other one, targets the T cells. So it just brings them together. It's going to be presented for the first time at the ASH meeting. This is in a couple of weeks from now. So they will show what's the phase 1 study safety. But the graphs are out there. The graphs that look at the efficacy, and I believe it's 3 patients treated at 800 micrograms, where they have 3 of them, I think, are in a CR, and 2 of them are MRD negative, so very deep level of response. The problem is it has a short half-life, but I think there's other antibodies similar to that are in development, and in fact, we have clinical trials with them here.
So the Mayo is working on it?
We're working on those trials, yes. We have some of them open already, so. There's a possibility, and Leif was talking about this, that if you have chronic immune stimulation, there's a greater chance that there's going to be the right environment for those cells to grow. Just like we think maybe that has to do with the microbiome and the bacteria. It hasn't been very clear that, okay, if you have this disease, you're going to get myeloma. But I think most of us think that if you live in an environment where there's chronic immune stimulation, someone who has rheumatoid arthritis or someone who has lupus or something, there's probably going to be a high risk that things might go wrong with cells in the immune system. So that might increase the likelihood of that happening. But it's not a major risk factor when you look at the big picture. Well, we don't know. The administrative papers say 7 years, but the way they're stored, they probably are good for a very long period of time. So the cells, when they're frozen in this media called DMSO. Mm-hmm. And the reason that DMSO exists there is so that there's no crystals that form in the water when it freezes. So the cells can freeze, and when they thaw, they're perfectly fine. That's what people were freezing themselves for, cryogenics, to be like Walt Disney into the future. So I think those cells are going to be very good for the long term. If sometimes we have doubts, we can take out a few of them and then test them and see how they grow and decide on whether they can be used or not. And if, for some reason they were not good, the cells were lost, I've never seen that happen, but if something happened, you can always recollect stem cells. So sometimes they are. There's a lot of stored stem cells that are kept in the banks, and then, sometimes they have been discarded or they have been used for research. Depends on how the consent was signed when they were collected. The way they can be used for research, they can be anonymized. So we actually are going to be doing some projects with them We have a research project with Arizona State University where we're going to be looking at a virus to see if that virus can help attack the myeloma cells. It's a different virus from the ones you heard from Dr. Bergsagel. It's called a myxoma virus. It's a virus that predominantly affects rabbits, but humans, we nothing happens when we're exposed to that virus, and it turns out to be quite toxic to cancer cells. So we're exploring that, and the idea is, can we use some of those cells to use them as delivery vehicles to get that virus into cancer cells? But for the most part, that would be their only use for research purposes. I think, yes, so one could inquire, and with the bank where it was stored, where they are. If a person unfortunately passes away and the cells are stored, then after a number of years, they would be discarded. Cancer cells are very selfish, so they take a lot of the nutrients from our bodies. And that's why when a person has active cancer, one of the things that happens, it consumes a lot of the energy that we have, and that's why people are fatigued and tired. But having said that, there's very little you can do to change the environment in your body so that it would be favorable or not to cancer cells. So if you had a way to lower your blood sugar, you would faint a lot faster than you could actually affect the cancer cells. The same is true with a pH. As you know, people sell this water with pH. If you could change your pH, you would start having seizures. So that's impossible to do with those waters. It's just a great business idea. In fact, unfortunately for a lot of people who spend money on that, and the company just had to pay a big lawsuit because it was considered that it was fraud, pretty much. So the pH doesn't work, and the same is true for sugar. If I would have a patient stop eating any, and particularly people like to put the word processed sugar, if somehow it becomes magically bad. But if any sugar is sugar, and if you stopped consuming sugar, then the body's going to make use of proteins and everything else to form sugar, because the body does not tolerate low sugar, because our brain depends exclusively on sugar. Our whole body is geared to protect our brain. And we need a certain level of blood sugar. You can go high. We can do better with high, even though that's bad in the long term, like in diabetes. But low blood sugar is very, very poorly tolerated. So there's nothing really that can be done. The cancer cells do take sugar, but they take other nutrients. When we do the PET scan, we use that labeled sugar, and that's how the PET scan shows those markers. But there's very little one can do from the diet to change that process.
It used to be at some point that androgens were used in patients who had anemia. This is back in my father's day. And they helped with the anemia in that case. We have much better treatments now. We have something called erythropoietin or Procrit to deal with that. And so we don't use sex hormones, estrogen or androgen, but the dexamethasone is kind of the same category of drug. And of course we use that.